and good afternoon to everyone, and welcome to the final day of the Rural Telementoring Quality Measure Toolkit mobile app launch week. I'm Wari Allison. I'm the director of the Rural Telementoring Training Center. I'm also VP for Health Policy here at the University of North Texas Health Science Center in Fort Worth, and executive director of the Center for Health Policy here, within which the Rural Telementoring Training Center sits. And I am moderating our discussion today. Note that we are recording this session so that we can share it later. Anything you type into the chat doesn't appear in the recording. This session is also enabled for closed captioning. You can access that by clicking on the More menu at the bottom right of your Zoom window and selecting Show Captions. I hope you've been able to join us for all our other events this week to share digital solutions for rural health. We've heard about a number of different things. We've heard about the use of podcasting to share stories and grow rural health leaders, key considerations for digital equity in an increasingly connected world, and telementoring solutions for some of the most intractable challenges of incarceration healthcare. If you missed any of these, you'll be able to access the recordings through our RTTC website and YouTube page, and those links are going to be dropped into the chat. Throughout this week, we've really been celebrating the launch of our Telementoring Quality Measure Toolkit and mobile app, which puts an evidence-based telementoring quality measure toolkit in the hands of organizations that want to establish new or improve existing telementoring programs for rural America. The app features different things, but in summary, it has a section that has introductions to key models of telementoring. It has a section that is an overview of the Rural Telementoring Training Center's individualized, tailored training and technical assistance process. And then it has the quality measure checklist for 5 different telementoring models to support their launch and sustainability. The app is now available on Google Play. It's pending availability on the App Store, but we're hoping to have it up there within the next couple of weeks. If you search RTTC, you'll find it, or you can navigate directly to it from the website for this event. And that will also be dropped into the chat, the web page, sorry, for this event, which will be dropped into the chat. This app and this week represent the culmination of a lot of work by a dedicated team. When we launched the RTTC, the Rural Telementoring Training Center, now back in the fall of 2020, that was just 6 months into a global pandemic that was really rapidly accelerating at that time. It also rapidly accelerated the use of telecommunications in healthcare. One of our goals was to define evidence-based quality measures for telementoring models and the measures of quality of the actual telementoring model. Nothing like that existed at that time, even though telementoring itself, as you all know, has been around for decades. And so we set out on this journey of discovery. We reviewed thousands of app publications. We interviewed telementoring leaders across the country, some of which are on the panel today. We established a consensus, and synthesizing all of these gathered data, we produced this single toolkit. We wanted something that was really practical rather than prescriptive. And we wanted a tool that would give implementing teams valuable guidance while allowing room for them to innovate and adapt to their needs and the needs of the communities they serve. And so the result is this Telementoring Quality Measure Toolkit. It's freely available. We have it in different formats. We have it in a PDF form. It can be an online access via an online survey. And now we have it in this mobile app. I think it's really important to acknowledge and thank the many people who've supported us along this journey. Our funder, HRSA, the Health Resources Services Administration, specifically the Federal Office of Rural Health Policy, our steering committee and partners who are at the UT Health San Antonio and its libraries, Oklahoma State University Center for Rural Health, Purdue University, Cardia Services, National Organization of State Offices of Rural Health, National AHEC Organization, and all the South Texas AHECs. Also many experts across the country who gave their time and knowledge to this endeavor. And last, but by no means least, to really the incredible team that I'm really privileged to work with, the RTTC team, particularly Trisha Melhado, a shout out specifically to Trisha, who's our evaluation lead. So without further ado, let's move on to our session, which I'm really looking forward to. Our panel discussion today features telementoring program leaders from all across the country who are here to tell us more about how they are building virtual connections that improve rural health. I have questions and topic areas for them, but I also encourage you all that are joining us today to drop questions in the chat, and we'll get to those. We want to get to those. Today, we also have Afonso, who's a live artist from the Sketch Effect, joining our event, and he'll be actively listening to this conversation throughout today's discussions, and we'll be bringing to life visually, in a visually compelling and memorable way, what we're talking about today. We're pinning his artist canvas so you can follow along as he illustrates our conversation through drawing images. We'll also check in with him later in the session to see his work, and we'll share that with all of you after today. So let's start with some introductions. So I'm going to ask each of our panelists, when I call on them, to unmute and introduce themselves and tell you a bit about themselves and where they're based. So I'll start off with Dr. Paula Stigler-Granados. Please, can you unmute and introduce yourself?
Good morning, good afternoon, everyone, and I'm super excited to be here. I didn't know about Alfonso doing this live action drawing, so I'm super excited about this, to see it. So I'm right now I'm currently at San Diego State University, and I was at Texas State University and UT Health San Antonio, so I know several of you here from my work in Texas. And hopefully I'm following directions on what I'm supposed to say, but I work mostly with Chagas disease. And if you've never heard of it, I'll give you some background on that today, but also it is a neglected disease that the World Health Organization this year finally decided to say out loud that this should be a disease that is handled at the primary care level. And that includes in the United States, where we do find this disease more common than we probably would think. And so we're integrating this into a primary care level, but it requires expertise that primary care physicians may not have. And so telementoring for this topic in particular, especially that it highly impacts rural areas and neglected populations and underserved populations, is a perfect subject for telementoring. And so we utilize this idea and concept quite a bit over the last 8 years now. And so I'm happy to be here to talk about that.
Thanks so much, Dr. Granados. And BJ Biskupiak.
Yeah, hi everybody. I'm happy to be here. I manage the Montana Asthma Control Program with the Montana Department of Public Health and Human Services. We're kind of buried in the Chronic Disease Prevention and Health Promotion Bureau, but we try to work across all different sectors, work with our communicable disease partners, local public health, and health care systems all throughout the state. I won't go into too much detail. Maybe I'll save that for later, but I will say that we do have several different types of telementoring that we've tried to kind of dip our toes into, and some things that we're still getting into, especially with online curricula and things like that for community health workers and other healthcare professionals. So I'm excited to be here, and I'm excited to contribute.
Thanks for being here. Dr. Jeffrey Wyeth.
Good afternoon, everyone. I'm joining you from New York and representing our clinical education initiative. So New York State Department of Health AIDS Institute has had a program to educate healthcare professionals throughout New York State for, I want to say over 15 years now. Initially focused on HIV, later expanded to sexual health. And our center is a relatively new center. We're in our 4th year, and we're charged with providing training to healthcare professionals throughout New York State in the topic areas of hepatitis C infection and drug user health. And I serve as the associate director of our center, and really pleased to join you. I've collaborated over the past few years with the RTTC and I'm just so pleased to be part of this panel.
Thanks for being here today. And then Rodel Bobadilla.
Hello, everyone. I'm Rodel Bobadilla. I'm from UT Health San Antonio, specifically from the Reach Center, Center of Research to Advance Community Health. I'm a public health professional and community health work instructor in my community and in my programs. I serve as a program manager for the UT Health San Antonio AIDS Education and Training Center, or AATC, and the STOP HCC-HCV program, which is also a long acronym. It's Screen, Treat, or Prevent Hepatocellular Carcinoma or Hepatitis C. I have collaborated with many community members, leaders, clinics, and organizations to connect them to services, resources, and research opportunities, which I think is incredibly important. My current health topics is around HIV and hepatitis C as well, and I work with a large array of the workforce, all from social workers, case managers, up to mid-levels and providers of both HIV and hepatitis C. So it's really great to be here today. Thank you.
So thank you all so much for being here. Really, really appreciate your time on a Friday afternoon. Really terrific to have 4 states represented here. So Texas, California, New York, and Montana. As I said before, I really have been looking forward to this conversation all week. We'll start by learning a little bit more about how each of you utilize telementoring to improve rural health. So I'll address this question first of all to Mr. Biskupiak. What health topics are you addressing? Which telementoring models are you using? And who are your learners?
Sure. So I'll address this from the perspective of our asthma home visiting program. That's primarily what I oversee. We do have other chronic disease programs that also do some of this telementoring work as well. But for my purposes, I'll focus just on asthma. So here with our program in Montana, we address guidelines-based asthma care, asthma self-management education, and environmental factors contributing to asthma morbidity and mortality. So that means one thing that we're trying to also do, one thing I'll add is that we're trying to explore more deeply how upstream social determinants of health impact individuals with asthma in our state as well. So these are all kind of different components that may cross over into some of our telementoring that we do. So the different models that we've used here in Montana are, one is webinars. Now we've been doing webinars for many years, with the primary audience being healthcare providers at various levels. And then with those webinars, we try to do about 3 a year. So, and those topics are typically as asthma related as we can get them, but there are some kind of tobacco cessation, things like that may, or kind of COPD asthma overlap. So some things that may branch out just a little bit outside of asthma, but are still asthma focused. Our asthma home visiting contractors are encouraged to attend these webinars, but we do also invite all of our asthma partners that we have on our kind of our listserv, which at this point is over 1,100 people. So, and again, that is comprised of healthcare providers, public health, and also school health professionals as well. So that's one way. We also have a podcast that was just started recently, and I know many of you may know Jennifer Van Sickle. She's kind of the spearhead of that podcast project here in Montana, and that podcast is called Talking Health in the 406. So Jen does a wonderful job moderating and producing those episodes, and we have over a dozen podcast episodes now, ranging back to last year, just to early 2022. So it's kind of a new model for us here in Montana, and it took a little bit of work to get that approved and kind of get through the process, but we're excited to bring that to Montanans. And kind of the audience of that is general public, but we try to distribute to that to all of our kind of public health and healthcare partners as well. And those topics typically include up to this point kind of chronic disease, or it could be EMS type topics as well. So kind of growing up with diabetes, overcoming the loss of vision as an adult, losing a child to uncontrolled asthma was a recent podcast. So really compelling stories that I think can help communicate our messages and educate and empower Montanans in a different way. So we're excited about that. And then just lastly, I'll say that we also use online modules and curricula. Historically, over the past several years, we've maintained a creating asthma-friendly schools and childcare training for school staff and for early care and educational professionals. And then with the help of RTTC, we've also been building out a training for community health workers with our state AHEC program. So those are the three big models that I think we've pursued or that we're really trying to grow here out of our program.
Thank you. So same question to Dr. Weiss. What telementoring models do you use, and who's your audience? Who are your learners?
Thanks, Dr. Allison. So New York State, most people think of New York City, but there's actually a lot of rural areas of New York State. And while we're charged with providing education for all healthcare professionals in New York State, the funder really wants us to focus on outside of New York City, which embarrassingly, what we call that here in New York is everyone talks about ROS, rest of state. So it's New York City and the rest of the state. I wonder how they refer to us. But in any event, we're very focused on the more rural parts of New York State. And CEI has always been an in-person training program. So our center was funded in the fall of 2019. We were gearing up, we were developing our programming, and we never did a single in-person event until about a month or two ago. So what we have been offering for the past almost 4 years are virtual webinars, conferences, creating podcasts, and I think we could have been certainly one of the first to develop a virtual preceptorship. So one of the important parts of our programming are to identify, centers of excellence in Hep C and drug user health. And then again, in the past, we would send 10 trainees to the center at the same time. They would have meetings in person, undergo shadowing. Our first preceptorship that was held in the spring of 2020 was virtual times 3, meaning the preceptees were virtual, all of the treatment being done was via telehealth, and our involvement from CEI was also virtual. So, we have, as everyone, been forced to innovate and come up with new models of virtual telementoring. And, I think one of the things our overarching program now is really evaluating is when to offer in person and sort of what are the parameters, when does that make sense, and what types of trainings are best offered in person as opposed to via telehealth. And again, our content areas are hepatitis C from screening to treatment, and drug user health, broadly focused on training medical prescribers. That is really our target audience.
Thank you. And Dr. Stigler-Granados, your telementoring models and your audience and your learners.
Hi, yeah, so the models that we have been using so far are the ECHO models, and we've had a lot of really wonderful success with our ECHO models. And I have 2 different models that we're using. One is aimed specifically at mostly healthcare providers, but we've also found that whenever I reached out to our networks, that we had also a lot of state and local health department officials join us on these discussions that we've had. We have specifically, we're targeting at the beginning infectious disease physicians, because Chagas disease falls under this infectious disease idea, but we really wanted to engage primary care physicians as well. So we've reached out through different topic areas with OBGYNs, infectious disease physicians. And again, oddly enough, we have veterinarians, entomologists, local health departments calling into these sessions and having lots and lots of questions. And so The ECHO model helped us to branch out beyond physicians because we really feel that we have a network of people. Chagas disease is a zoonotic disease, so it falls under the One Health model. And so we really have to bring in more people that are doing surveillance. And so that's really been who we've had using our models. And the other one that we're using for our ECHO model is the community health worker model. And using our AHECs to reach out and have these series of tele sessions for them on with using the ECHO model for learning about Chagas disease in small pieces, because it's a very complex disease. And that's been really, we're actually right in the middle of a series right now. We just launched another 4-part series on last week, and we have another one, or this week, actually, we have another one next week, and we're actually piloting it as an evaluation for a national accredited curriculum that we like to have as a train the trainer curriculum sponsored by the CDC. And then lastly, we are branching out into a podcast. And I just needed to say that Talking Health in the 406 inspired me. I heard about it, I listened to it, and I started thinking to myself, we could do this on Chagas disease, and we're going to branch out into zoonotic diseases, because I don't know if anybody really wants to listen to a bunch of podcasts about one particular disease, but zoonotic diseases are very interesting. So we're talking and exploring ideas about what bit me last night. Something that's just kind of creepy crawly diseases that we really need to be talking more about with our primary care doctors. Again, rural areas are our target places, because this is where we find more of the disease, especially as we've noted in like Texas and the rural areas, which is where I primarily focused on. And that was actually where we started our echoes. And now we've branched out to the entire United States. And as Andrea knows, who helps me with these echo sessions, we've got people calling in from all over the world now. And so I can literally, with our echo model, we can send out a blast on Wednesday or Thursday via tweet, and we will have 150 people online by Monday. So really interesting how once the people like the ECHO model, the CDC helps us also with this, because they love echoes. And so that's been a lot really supportive. So that's the models we use. That's our target audience. And I think we're reaching them. Podcast to be continued. We'll talk more about that.
And Riddell, your telementoring models and your telementoring models and your audience. Mr. Bovadilla, sorry, go ahead.
Very good. I would be interested to hear about that podcast, Dr. Riddell. Sounds great. I'm just looking like, wow. So through the ATC, we use a lot of telementoring models itself. We do webinars. We have a lunch and learn that we do monthly with our local health department that's been really great all around sexual health, since we are focusing on HIV specifically within the ATC. We also launched a virtual preceptorship program, although I think we did it in the fall of 2020, Dr. Wise. So I think you were still first to do that as well, where we bring health providers, health professionals interested in treating HIV to our community clinics here in San Antonio. So I think that was a really great experience to do as well, and build out that protocol and that virtual component and mentorship component for them during a global pandemic was great. We also run 2 HIV echoes. One's an English-focused HIV echo that has been running for 4 years already. That we built in a fellowship rotation in it as well, just to engage our fellowship here in UT Health San Antonio. And like I said, we do twice monthly. It's been running for 4 years. We have a great built learning network that is actively engaging with us. And then we try to listen to our communities and bring in speakers that interest. And I think that's what kept them going for so long and had some constant attendance to it. We also have a Spanish HIV echo, which runs more internationally. We have participants from the Dominican Republic, which is a lot of our mainly rural clinics join, Puerto Rico as well, and Mexico too. We've had people join. And this is a purely Spanish echo. So we use simultaneous Spanish to English translation. And that learning network, that community has been really astonishing to me. And I could talk about that later and how that relationship has built and evolved in the sense with Spanish speakers here in the United States and overseas as well. And then we also have, through our STOP HCHCV program, our individual consultation, or what we call our teleconsultation model. We work with rural primary care clinics here in South Texas, and with FQHCs, Federally Qualified Health Centers. We know that time isn't always available. They're constantly having to see patients. So we had to build a model that really fits their needs and their time needs specifically. So this teleconsultation model that I could talk about more as well has really been beneficial to try and engage providers to treat hepatitis C within their rural clinic systems, which has been great. And then we work all throughout the HIV workforce, HIV care continuum and hepatitis C care continuum. So from community health workers all the way up to mid-levels and providers, nurses and LVNs, we try to target every aspect of the care continuum for both HIV and hepatitis C.
Thank you all for those responses. So workforce is a really important part of delivery of healthcare and a number of other things across rural America and rural communities worldwide. And so again, this question I'll pose to all our panelists is, what do you see as some of the primary challenges facing the rural health workforce in your area? And I'm going to keep you all on your toes. You don't know which order I'm going in. I'm going to start with Dr. Stigler-Granados with that question.
Oh, you are keeping us on our toes. Challenges, in particular, well, so now that I moved back to California, that I could talk a little bit about that, is that out here, I feel like the rural areas are really, there doesn't seem to be a whole lot of connections with some of the larger cities. And there's quite a bit of rural areas out here. I'm really struggling with reaching out to our rural providers here in California in terms of what they're doing. We have a robust community health worker network, but they're disconnected from the state, unlike it is in Texas. And so I'm just now starting to feel out how to get into these rural areas where we have a lot of migrant farm workers and we have a lot of people that are not connected to a healthcare system. And then working in Texas, some of the bigger challenges with doing the work that we were doing, and even beyond that, is just the fact that I think that the topic that we talk about, Chagas disease, not only is it neglected, but it's also completely unknown by most people. I mean, I don't know how many of you, besides the people that I work with closely, have ever even heard of Chagas disease. Don't Google it at night while you're laying in bed, because it's it's one of those things that I tell people not to do. But it's something that has stigma attached to it. It is considered a disease of poverty, but it also affects everyone at any level it's possible, especially if you live in the rural southern part of the United States. And so I feel like some of those challenges are getting through the stigma, getting through the physicians to actually be able to talk with their patients about this, and feeling like they are able to talk with their patients when their patients come to them with these questions. And so our entire target from the CDC has been to target the physicians before we target the general public, because the disease is so complex. And when our patients go to the physicians and the physicians don't know anything about it, we want to make sure that they're empowered to provide that information or connect those patients to people who do know about the information. And to be quite honest, in rural areas, they can't necessarily have the ability to send their patients to the city to get treated by an infectious disease doctor. And so having them have those connections with other providers that can walk them through the process is our biggest challenge.
Yeah. Mr. Bobadilla, rural workforce challenges from your perspective in your area.
Time, I think, is one. Providers are always busy, especially in rural clinics. I think they have a lot more responsibilities than someone that's within the state, just because they have to act on the full, they have to act on the patient, right? Like a full aspect of care, just because the resources aren't always available. Stigma also plays a lot, especially when we're talking about HIV or hepatitis C. A lot of providers in rural counties don't exactly know how to engage their patients on HIV or hepatitis C, just because themselves maybe haven't been trained on it. And they just think their patient population won't respond well if they are asked to screen for HIV or hepatitis C specifically. So that's still something we deal with. And then I think clinic culture too. I think going into a well-established clinic, and especially in a rural area that are used to doing things a certain way, you coming in and really trying to change anything that they already um, are used to can be very difficult. So doing a telementoring program virtually when they're not used to it, I know in the beginning, was very difficult for us to get them on board. Once they saw it working, that's so we really needed to prove ourselves, basically make sure that this program was a resource to them and it was helping their patients.
Mr. Biskupiak, in your neck of the woods, what are the challenges around the rural healthcare workforce?
Yeah, I think in Montana, our biggest challenges that we face are typically with long distances, isolated and small populations, and then difficulty in recruiting medical professionals to those smaller communities. So in Montana, I think compared to these other states, we might be the most rural. I know Texas might be able to give us a run for money in some locations, but 74, I was looking at this, and 74 of our 122 small communities have populations below 1,000. So that's where that isolated and small population issue kind of comes into play. And what we see in a lot of those communities are that the rural areas tend to have a higher proportion of, excuse me, of elderly residents. So that typically requires more care and some more specialized care in different aspects. And then what we also see along with that kind of the long distance is getting patients in the office for needed care can be a challenge due to those long distances. So where we come in trying to work with providers on evidence-based asthma care or whatever the evidence-based care would be for that specific condition, it's getting them that education, making sure they don't feel isolated when they don't necessarily have other providers around them to consult with. And then really focusing on that recruitment and retention piece. I think a part of that we see is mental health typically comes to the top of the list when providers are asked about kind of satisfaction or reasons for leaving a place, kind of some of these smaller communities. So when I say mental health, I mean lack of allied mental health workforce or mental health care, or those providers then end up having to kind of provide that mental health care that they may not feel qualified for. So those are, so that's where kind of mental health comes into this picture as well, and is a big issue that we see. Even though there's all these other confounding chronic diseases or health issues, mental health seems to come back to the top of the list. So for us, it's trying to get those providers that education, and that's where this telementoring can come into play. But then also kind of work on those other aspects that may build up support around them, and help them feel a little bit more comfortable with some of those other kind of duties as a side, those other provider roles that they may not feel comfortable with in the beginning.
Dr. Weiss, rural healthcare workforce and challenges in your area.
I think one thing we've noticed a few different times now is that in the topic areas that we're focused on, sort of specialty areas, often in rural areas, there's one expert provider providing that care, and that doesn't lead to the request for training or telementoring because everything's going well. And then for whatever reason, that provider leaves. And that's when there's this, sort of crisis call for help. And, we had an experience where, in a rural area, the provider who was doing all the chronic pain management was leaving, and that was truly a crisis. And another area where the provider who was doing all the hepatitis C treatment was leaving, and that led to, we suddenly got 4 applications for a preceptorship on Hep C from the same health center in a very small community in upstate New York near the Canadian border. So to me, what that speaks to is sort of the need to proactively address expanding capacity, in rural areas where there might not be a request to do so because, everything is going well. But, as we all know, that can change at any moment.
So next, I'm going to kind of explore a little bit the theme of why choose telementoring, and why you all decided to go in that direction. So I'll start with Mr. Bobadilla. Why was telementoring appealing to you as a tool? There are other methods of teaching, there are other methods of training. Why telementoring?
I think when it comes to the echo component, having an expert hub team, a team of different healthcare professionals that are experts within their field, give guidance and mentorship to our providers was specifically very appealing to us, just because they have different perspectives. For our HIV echo, we have an ID physician, we have a pharmacist, we have a social worker, we have a psychiatrist on as well. So it gives them that full aspect of care to manage and treat their patients all in one place, where they could come to for an hour once or twice a month and get that guidance. It also has a learning network, so they feel like they're part of community, even though they might be in a rural town that might be isolated. When they join this network, they're with others who are looking for the same thing as they are and are also able to provide perspectives of maybe they're also in a rural community, but they found a way to navigate a certain issue that's, and they could share that with others, and maybe they could try it in their communities as well. So I think that's what was the appeal with the Echo. One, just having that expert hub team, and two, having that learning community where they felt like they were part of a community, even though they were far apart. I think that was great. For our teleconsultation model, which we also run, I think it was incredibly important. We tried to see if we could even establish an Echo in our rural FQHCs, rural primary care clinics, but providers just didn't have an hour of their time available to them, just because they're constantly seeing patients, and seeing patients come as priority, just to make sure that they're meeting their requirements in general as an FQHC. So we had to pivot and do individual consultations or teleconsultations, which are usually once a week. We call it our teleconsultation office hour. It's usually a one-on-one call between the provider, the LVN, and then we do hepatitis C for a teleconsultation. So it's our hepatologist on the line. And it's usually, we have a set formats, we have a set review form. Providers already know how to review patients, just case present their patients. And we usually do 45 patients within 10 to 15 minutes during their lunchtime, because that's when the only availability they have. They're able to get their questions asked, they're able to get a treatment recommendation, and then they feel more comfortable treating that patient because they spoke to the hepatologist. Even though it was very brief, they were still able to have that interaction and have that confidence now to go and treat that patient in their clinic system without having to refer them out. So I think that's what, those are the two models we utilize, and that's why I think it's incredibly important to have those. That's what's worked for us so far.
Mr. Biskupiak, why telementoring?
Yeah, I think telementoring models are appealing to us for two reasons. Number one, they allow scheduling flexibility in a world where most of our healthcare and public health providers are already very overburdened. So it allows, and I think that extends to some of our kind of other trainings that we have out there, our online curricula, those modules that we have for school health and childcare professionals as well, interested in learning more about asthma and how they can support their students and children. It provides them the flexibility to access those trainings at any time and kind of go through those on a self-paced type of model. So I think that has been very helpful for us, and I think that will be another very appealing feature to the CHW trainings that we're going to launch this summer. And then number two would be the element of cost savings that allows us to allocate our limited resources to other activities. So I think, just mentioning the distance for rural health, I think that's just something that we see with all of our partners is there may be a training once or twice a year, or some kind of conference they'd like to get to, but it just may not make sense, may not line up for them. So for us to have the ability to provide these webinars or these other learning opportunities, we can bring in experts from outside the state as well, from really anywhere, and get that information to them, and kind of cut down on the costs for us and for them to get some more training and education. So those are, I think, the two big reasons that we think of.
And then to Dr. Stigler-Granados, why telementoring in your context?
Yeah, I think I mentioned earlier that because this disease is so specialized and complex, that telementoring really works for those providers that have never heard of the disease and are presented with a patient that they think, like generally most people find out they have it, but they donate blood and they get a positive blood test from the blood donation center, and the doctors don't know sometimes what to do with that. So that telementoring really provides opportunities for connections with experts. And just like Rodell was saying, and I put in the chat too, like, oh, what a great idea. We could have these like drop-in sessions with the experts to talk about cases. And so that was really inspiring for us. And I think this idea of the podcast that's coming up next, which I'm really excited about, has to do with the fact that I've learned that a lot of physicians and providers are listening to podcasts for these little tiny nuggets of information, things that you can digest on the go when you have that moment of, you know, you're commuting your kid to school, or whenever you find those moments, and that just having these little pieces of information out there, recorded, available for on demand, I think is going to be our next big step for just, you know, here's some info and then here's some resources. And then I'm hoping that'll also connect them back to the bigger networks of service that we can help offer to them through our echoes and other sessions like that. So just getting the word out sometimes about something that people isn't at the top of their mind. And I think that that's the best part about the telementoring networks.
Dr. Weiss, I'm not going to ask you that question because you a little bit earlier spoke about how, you know, CEI initially was in person, and then how with you had to kind of pivot, and you've been mostly virtual for the last few years. I'm going to pivot a little bit and talk about the mentoring part of telementoring. You know, a core part, obviously, of the word telementoring is mentoring. And I want to kind of ask you, you know, what does that word mean to you, and how do you incorporate that into your programming at CEI?
You know, I think one thing that we've noticed is there are certain individuals that they're on all of our webinars, and they're sort of like our, you know, best customers. And so we've used that as an opportunity to reach out to those individuals and, you know, one, try to assess, you know, one, to thank them for, you know, being such an important part of the work that we're doing and supporting it, but also to assess their specific needs. You know, because we feel that if someone is so focused on the content areas, they might be able to guide us in our future program development. And similarly, yeah, another thing I didn't mention is we have something called the CEI line. So any healthcare professional can call a phone number, same phone number for all the centers. So if the question's about HIV, it gets sent to the HIV center. If it's about Hep C, it comes to our center with any clinical question. And within 24 hours, an expert clinician will get back to them. And we've also used that as an opportunity to then, you know, not only answer that question, but to see what sort of programming we might have that could further support that individual's work, and, you know, use that as an opportunity to engage them. So, you know, I think, you know, most of our programs are, you know, 50 participants on a webinar, but we try to individualize in those ways to really, you know, also provide mentoring, which I tend to think of, you know, as a one-on-one type of relationship. And obviously, it's not exclusive to that, but to make sure that we're also really giving individualized attention to those who seem to be indicating an openness to it.
Thank you. So Mr. Biskupiak, I'm going to go to you and ask you a little bit about how you've interacted with the Rural Telementoring Training Center to support your telementoring programming.
Yeah, I'm just one handful of people, I think, at the Montana Department of Public Health that have really benefited from working with RTTC. I've participated on several guidance calls with RTTC team members over the past couple of years to really help narrow down the focus of our community health worker online curricula. Through that partnership, we've received different tools that have really helped us kind of refine the outline for our course, and then really develop quality learning objectives and learning assessment questions as well. So part of that is trying to make this training as interactive as possible, but then also kind of interactive and engaging as possible, but while still getting that important information across. And through the partnership, I was also connected with public health counterparts in Texas who have provided their expertise as well. So, so that was a great connection to kind of see how things are done and other programs with CHWs, where our network of CHWs in Montana is still kind of growing, and we're still trying to understand how the CHWs will be utilized here in Montana. So it was great to have that connection as well, to see a program that's further along and how things have gone for them, and kind of what information they're looking for, or what would be helpful for them in terms of asthma and evidence-based care. And then that partnership has also led to the production of a series of CHW kind of asthma visit scenario videos that will be incorporated into our training. So that's kind of a fun, exciting, just another exciting piece that came from that partnership. So couldn't be more thankful.
Well, we've enjoyed working with you and hope to continue to work with you going forward. So next, kind of more kind of setting the scene a little bit. This is to Dr. Stigler Granados and Mr. Bobadilla. So Chagas disease and hepatitis C are different, obviously different infectious diseases, but they have some interesting similarities, right? They're hidden diseases. They often present with minimal or no symptoms. They are stigmatized, both of them, poorly understood by the community and the health system. And their treatment and care has historically been located in very specialized settings with specialists, which limits access. So for these reasons, it makes it difficult to identify and recruit learners, or even to discuss cases. And so can you tell me a little bit, both of you, somebody can jump in first, but can you tell me a little bit more about how telementoring has played a role in giving visibility, right? Visibility in a broad sense to what is an under-recognized area that should be a priority and is becoming more of a priority.
Thanks, Lori. I'll start, if that's okay, Rodel. I think for Chagas disease, because it is such a neglected disease, I think you know, when you call out these similarities, it's really uncanny how similar they are. I think hepatitis C, though, I think because hepatitis is a little bit more spoken off the tongue, physicians generally are a little bit more knowledgeable of it. With Chagas disease, some people have just completely isolated it to Latin America. I don't think we have it in the United States, but we absolutely do. Not only do we have it in the United States, we also have it amongst populations of people, a lot of people who come from Latin America. And so providers need to know how to treat that disease. And I feel that the more echo sessions we do, because echo has its own visibility in and of itself, the more intrigue I'm getting from providers. They're seeing these connections like, oh, I should be screening my pregnant patients that have lived in Latin America, or that their moms were born in Latin America. This is passed from mother to child. I didn't think about that. So I really feel like it's given me an opportunity to do a lot more extensive outreach on a disease that people don't, like, as Raudel really well put, there's very busy people with a lot of other important diseases to think about, diabetes and, you know, these chronic conditions that really are pervasive in our society. And so Chagas disease is not at the top of that list. But just for me, getting providers to think about their population that they serve. And that was similarly, and Raudel, you can chime in on this too, with Hep C, it's a very specific targeted population. Well, Hep C is pretty broad, just like Chagas disease, it can affect anyone, but you have an idea of how you want to target that, and getting providers to see those connections between the patients that they serve and the possibilities that they maybe want to screen for this silent diseases has been pretty cool. So I find people calling into these echo sessions, I had no idea that they would be interested in it, but they see a tweet about it and the colleague is talking about it. They get a free CME out of it. And then the next thing I know, we get them hooked into this world of visibility, and eyes get opened.
Yeah, definitely. Thank you, Dr. Granales, for that. I think for us, our main thing is our providers were really hesitant about screening for hepatitis C because, especially South Texas, has a large uninsured population. We have an expanding Medicaid. It's really hard to get services, especially in rural counties. They didn't want to open that can of worms. They didn't want to diagnose a patient with hepatitis C, then have no resources or access to care for that patient for treatment. And what this telementoring model did, our teleconsultation model did, is instead of the provider having to seek out and reach out and try and find a hepatologist to help, we were bringing a hepatologist to them weekly in an hour, and they could talk about their patients and they could get treatment and get treatment for their patient and treatment recommendation for the patient, how to best manage the patient as well. And I think that was extremely helpful. So what we did really is advertise that we're bringing a specialist to you. You don't have to seek them out like you're used to doing. They are here to help you. They have dedicated time to hear you out, for you to discuss the patient with them. And they're there to make sure that you're able to treat your patient in their medical home without having to refer them out, because Hep C is very treatable. It's easy to treat. Any provider could treat, mid-level could treat. And I think that was what really helped us get into the community and get providers on board, knowing that they have that specialist. Because I remember when we initially went into our rural clinics and told them that we're going to be screening for hepatitis C, that was our main concern. It's like, well, what am I going to do with them once I find out they have it? Because I don't want to let them know they have something and not be able to do anything for it. So they were extremely hesitant. But once we let them know, and once they saw our model and our protocol, they got really comfortable. And then once they started treating the first patients and they cured them, now it's like, okay, I could screen everyone now, and I know I have a resource for them. And now we're doing 4 to 5 patients a week, every couple of weeks now. So they've gone through, and our NPs are the one really leading the cause, and I think in our program itself, we've cured over 230 patients in these rural, small little clinics. So I think letting them know that this program is there to benefit them, and we're bringing specialty care to them, I think has really helped increase that visibility for us.
So as I said earlier, one of the things that the COVID-19 pandemic did was really ensure that the future is certain for telecommunication technology in healthcare. It's accelerated growth in this area considerably in many ways, and there's no going back. But despite this rapid growth, there are challenges. And so I'm going to ask each of you some questions related to that. So starting with Dr. Weiss, as you reflect on the work you've done to design, launch, maintain telementoring programming, what has been a pain point for you? And after Dr. Weiss, I'm going to come on to Mr. Bobadilla with the same question. A pain point, Dr. Weiss.
So, I think what comes to mind is back in spring of 2020, suddenly everyone was so hungry for contact. Everyone was sitting around and didn't have much to do. And we would get 80 people register for a webinar and have 75 attend. And what we've noticed is over time, we now sort of expect half of the people to attend who register. And that always intrigues me. And sure, like, we make it very easy to register for a webinar. You click on something and put it on your calendar. But, even if we're all very busy, and if you take that effort, it means that you did have some interest in the topic and had some intention to attend. So, I don't want to see those percentages continue to go down. So, and I think obviously there's also Zoom fatigue and, webinar fatigue. So how to innovate in this space. And I mean, Alfonso is providing such a great example of that type of innovation. How to engage people, how to keep them engaged, not just in the content, but in the format of how you're delivering your telementoring.
Rodell, do you have some thoughts on that?
No, yeah, definitely. I believe innovation is needed. We can't be repeating the same type of echoes over and over again. So I think a pain point, it's really been more work for us to try and bring in culturally and just relevant topics within our fields.
I think Rodell's connection has frozen. So I'm
trying to engage.
Sorry, we lost you for a second there, Rodell. But I'm going to move on to, I want to end on a high note with the next kind of question to Dr. Stigler-Granados and Mr. Biskupiak. What are you excited about for the future of telementoring and rural health?
I'll go first. I'm super excited about Chagas disease being on everyone's radar at some point in time, and us learning more about screening and diagnostics. I'm super excited about this podcast, and just having a platform and echoes are fantastic too, but also just having another platform that's like non-committal for some people. That's a little bit not fun. It's not necessarily a fun topic, but we can have a little bit more freedom to talk about some of the problems with the system of not being able to screen and diagnose, and uninsured and insured, and all of these issues at a level playing field where everybody can listen and have all experts talking about it. So I'm super excited about elevating the topic and reaching a bigger audience and just getting people to see this disease for what it is. I'm excited about that.
Mr. Biskupiak, you're last up for high note.
All right. Well, I specifically thinking about our work with community health workers here in Montana, and healthcare facilities, both big and small. We're just really excited to see how that workforce grows, and how they find their way into these different positions will be an ongoing challenge, and how they'll be utilized. But I think we're just excited to be in kind of working with our partners, whether that's our state AHEC or our different healthcare partners, to make sure that those CHWs are educated on asthma, diabetes, whatever chronic conditions we can, and not just other needs that they can address. Just making sure that we can do our part to make sure they have the most up-to-date education that they have. So, and I think there's a lot of different exciting module or types of telementoring to do that, and so we're excited to expand that beyond just our webinars and our online curricula as well.
So we've just got some time to check in with Alfonso on how the live sketch is coming along. You're up, Alfonso. Let's see, have a look. Yeah, that's looking pretty great. He'll finish out the sketch, and we, of course, we're going to share it with you all. We're nearly on the hour. Time just flies. I really want to thank everyone as Alfonso is scrolling through the illustration. I want to thank you all for joining us this past week. Do check out our Telementoring Quality Measure Toolkit and mobile app by visiting our website. we hope to see you. We're having an upcoming virtual unconference that's October 18th from 10 a.m. to 2 p.m. Central, and that registration link will be dropped into the chat. Yeah, this has been a really great conversation. Deep appreciation to all our panelists who are all busy people for joining us. Deep appreciation to all of you who registered and turned up to join us this afternoon. Have a wonderful weekend.